Welcome everyone to another episode of the podcast. Bodine Ledden, joined by Shaun Brewster, and today we are discussing things that you can't release in manual therapy. These are often held to be true, these beliefs that we can release certain muscles or emotions or a number of different things, and we're going to explore a few of these. So, um, Shaun, why don't you kick us off with the first thing that we can't release in manual therapy?
All right, so let's frame this up first of all and just say that the term release gets thrown around a lot, right, within manual therapy. And for want of a better word, it's the one that gets used a lot. We talk about releasing things because you feel different afterwards. It feels like something's let go, especially when you connect it with something like cavitation, like a manipulation in a joint where something goes pop and then it feels released. And so I understand before we get into a real ranty, I understand why we use this term, and I acknowledge the fact that we teach a course called functional release cupping. If I could go back in time, I probably would have named that something different, but it is what it is. So we'll carry that forward for now. But the term release, when we apply it to different specific structures, is where we can very easily mislead people and misrepresent what we're doing. So my first structure for today, Bo, which obviously will make your eyes water when I say it, is plantar fascia. And you'll have a patient say, I've got plantar fasciitis, I've got plantar fascia, whatever. Can you release it for me? And I would always think, well, I'm not sure where I put my scalpel, but sure, I'll have a go. Right now, we're not going to release plantar fascia. One study showed us that it took over 600 kilos of load applied longitudinally to the plantar fascia to change its length at all. It's designed to support your entire body weight, which multiplies itself many times when we run and jump. And so what could we possibly do with our thumbs, fingers, or other implements that might release or change the length of a plantar fascia bow? Nothing would be my answer to that question.
Yeah, I mean, imagine that. If you stood on a sharp rock or a piece of Lego, then there goes your plantar fascia. It's a
Bang.
pretty strong, robust structure, and it is designed for transmission of force. You've only got to think about the amount of force that's applied through this structure and a number of others when we run or jump. And so if we could apply some gentle massage techniques, some myofascial release techniques to lengthen that structure, well, that just would be very unhelpful. So that's certainly something that we can't release with manual therapy.
100%. Agree. Agree. Bo, what's yours? What's your second one for the list?
My next one is the psoas major muscle with a manual approach through the lower quadrant. And this is something that I learnt and I'd done for several years. But when you look at this structure and the depth of it, as it obviously originates from the vertebral bodies of the lumbar spine and the transverse processes, it's really, really quite deep. It does come more anteriorly as it crosses over the ramus of the pubis. But when we're talking about releasing it, going through that lower quadrant of the abdomen, we've got to pass through firstly the adipose tissue, then we've got the external and internal obliques, the transverse abdominis, and then underneath that is intestines. So you might be mobilizing what they had for lunch, but you're certainly not releasing the psoas major muscle.
Yeah. So let's test this then for a second. But all these people listening going, but hang on a second. Someone comes in and I test the hip extension and I do this and it moves further or they feel freer. If I'm not releasing it, Bo, what am I doing?
Well, I mean, potentially it could be a mechanism of diffuse noxious inhibitory control. So applying a noxious stimulus that can inhibit the other painful stimulus. It could be that you're even having an effect on the obliques, the abdominal muscles through that area. Those areas may be perceived to be tight, all right, or sensitive or painful. So putting your hands into that area, yeah, you might have a response. You might have a pain inhibitory effect by applying manual pressure to that area. But we're not even close to having to directly contacting the psoas major muscle.
Okay, interesting. All right. My turn. I'm going to go a bit broader this time. I've often heard patients say, "Oh, I'm all jacked up. Can you release my back for me?" Well, What does that even mean? If you were to release, does that mean take your spine out of your body? What does release your back mean? Because, and again, I know we're playing on pedantics or semantics, I should say here, about around terminology and the words that we use, but these are important, right? The words we use with our patients are important. The words that they use and how those words perpetuate their understanding about what's happening for them is important. And so if we were to release your back, the structure that is so robust, so mobile, so able to withstand load and force and transmit load and force, then what would that mean for the back once it was released? Is it now unstable? Is it now unable to support you? Then, and again, we have to play this out with our patients. I'm going to release your low back for you. And they think, oh, that sounds great. And then their subconscious starts playing with that idea and says, well, okay, well, I feel pretty guarded at the moment because of my pain. And once you release it, will I then be unable to sort of control the movement? And what does that mean for me? So we don't release backs, Bo, do we? We don't do anything to them that will dramatically make them structurally different than they were when the person walked or hobbled into our treatment room. So yeah.
No, we can absolutely alter the perception of pain, the perception of tightness, or the perception of stiffness that can influence behavioral change and promote more movement or more comfort with movement. And that's fantastic. And I think that's where the real value in what we do as manual therapists lies. But having that structural narrative that some structure has to change is just not accurate. And in fact, I just came back from a wet lab, and you look at the robustness of these structures and how many different structures there are around the lumbar spine, and different layers of tissue. You know, these connective tissues through there, they are very strong, very stiff structures. And so we're not necessarily influencing the structure, but we can influence the perception of pain. And providing non-noxious inputs with manual therapies can help to decrease some of that spasm, the guarding, the sensitivity around that area. Absolutely. And I think that's fantastic. But the narrative behind what we're actually doing is very unlikely to be structural.
That's right. And this, speaking using the word narrative again, the narrative around the idea of a release is a structural perception. It's the idea that a structure will be in some way changed after I've done what I'm going to do to you. And we now understand that so much of what we do in manual therapy is about different inputs and then therefore different outputs. It's not the structural change, it's the perceptual change. It's about stimulating various different mechanoreceptors and proprioceptors and different neurological structures that then create neurological, chemical, and then functional changes for a person, not structural changes. And so I guess the crux of what we're getting at here is today is we don't really release anything. We change the way something feels. So we don't release your back. We change the way your back feels. Bo, what's your next structure to not release?
Yeah, the next one is the diaphragm. Uh, and again, I came back from a lab, and this is something that we hear a lot, doing diaphragmatic release. And you think about, how do you do that? Okay, so you'd have to come over the top of the lower part of the ribs. You would have to go through, again, the subcutaneous tissue, the abdominals, and then what have you got under there? Well, we know that the diaphragm, it sits on the back part of the ribs, right? So the posterior part of the ribs at the front. Okay. But we've also got the liver that sits under there on one side and the stomach on the other side. And I'd really encourage you to look at the diaphragm on an accurate anatomy app, or even better, go to a lab, and you'll see that it's this thin sheet, but it is really high up on the posterior side of those ribs, so on the inner surface. And so the chance of even getting your fingers even close to the diaphragm is very, very unlikely. So, people might say, well, I get really good results when I do diaphragmatic release. Well, maybe you're having an effect on the overlying rectus abdominis or the oblique muscles, but you're not getting to the diaphragm.
It's too far up. Yeah. Yeah. You can't climb in there. And I'm just going to throw another thought out there is talking about releasing muscles. And again, we're playing on semantics here, but if you were able to just poke a finger into a muscle and just gently kind of hold it as that muscle moves about, like we do, like we see with diaphragm release sort of techniques, then what would happen if you leaned against the side of your massage table while treating, someone for an hour and just sort of leaned into the side of it with your rectus, with your vastus lateralis, for example? Would then you not have a big dent in the side of that muscle? Would you not then have released the ITB or changed the structure or function of that muscle just by leaning against the edge of that table, which is providing a lot more direct and concentrated force than your fingers would for a minute or so up underneath the rib cage. So we're putting things in context here. There's, these gentle soft tissue techniques that we do. Yes, they make the patient feel different. Yes, they make them feel better a lot of the time. But we're not structurally changing the length of a if we could alter the size, shape, dimensions, length of a diaphragm, wouldn't that impact the patient's ability to breathe effectively? Wouldn't, making the diaphragm longer make it less responsive to contraction and therefore more difficult to take a deep, comfortable breath? I think that would be a negative thing, not necessarily a positive thing. So if the person's having difficulty breathing, remember, there are other muscles of respiration other than the diaphragm, and intra-abdominal pressure will make it difficult for you to breathe in and for the diaphragm to depress down. And so if the work that you're doing through the abdomen is altering perception and making it feel like there's more space in there, then maybe that's what's changing. Maybe it's the perception of ability for the diaphragm to move into that space, not the diaphragm itself changing. So anyway.
Yeah, and I mean, this is a topic for another episode, but when we talk about fascial release, and yeah, there might be some viscoelastic properties, but these effects that we might feel under our fingers are transient. They're short term. They're not changing the structure of the connective tissue, because as you said, that would be very unhelpful. Like how, if we went and ran a marathon, or if we played a game of rugby and our body just completely deformed to that, then that would be very unhelpful. And so you think about the pressure that we apply with manual therapy. Well, it's nowhere near the force that would be required to exceed that tissue's ability to stretch or lengthen or to change. All right, so the forces that we apply are nowhere even near that range. But yeah, absolutely, we can change the sensory input, which may have a reflexive effect on output. It can change the experience of pain and the perception. And the patient can feel better, and that's fantastic. But again, back to that narrative about what we're actually doing, where we can decrease a patient's pain, but we don't necessarily need to change the structure of tissues for that to happen.
Yeah, and that echoes into this idea of postural alignment and postural change, and the structural integrative sort of model where we're like, we have to move something to a different position for it to work better, because there's an optimal position for everything, which plays into my next one, Bo, which is the sacrum. People go, my sacrum's out, or it's jammed, or it's stuck, or it's tilted or torsioned or something. Can you release my SIJ, my sacrum, for me? And this is an interesting one when you think about the structure of the sacrum or the sacroiliac joint. It's a really stable joint. If you look at a real human SIJ, it's loaded up on both sides with a stack of ligaments, heaps of fascial attachments, lots of muscular attachments. The joints are created like a capstone in a bridge, designed like that last brick that goes in a bridge to make an archway so that load can be applied on top so that it doesn't cave in. It's designed to be strong. There are a lot of people out there that claim that it doesn't move at all. And so if it can't move at all, or even if it can only move a little bit, which I would say it can move a little bit, why would we want to release something that's designed to be that stable? And sure, patients will have episodes, moments in time, things will happen, and they'll get immediate and acute, intense SIJ pain. And then we'll do something like joint mobilization, or maybe some needling, or some soft tissue work, or something, and they feel like, oh, it's immediately better. You've released my SIJ, or you've put it back in, or you've adjusted it or something. And all of these terms are nice because it makes the patient feel like there's been a finite moment in time where something changed, where there was a correction. And we know no correction is required, different sensation is required. So when somebody's having that acute bout of, let's say, spasm or pain around the SIJ, our job is to provide a different stimulus. And so that acute pain episode can be settled down, And then any guarding that might be going on as a result of that can be settled down, and then the person can move more freely again. If it was easy, if we could do some of these very, you've seen them before, very subtle, very gentle sacral manipulations that kind of release anything in that region, then surely me sitting in this chair right now with all 80 something kilos of me pressing on my SIJ is going to put it out or put it in or put it somewhere. Or me stepping off a step and landing awkwardly on one leg is going to jam my pelvis up and then something's going to be wrong. When I can go for a run, jump up and down, chase my dog around, I'm fine, right? So the SIJ is not that fragile, nor is anything that we can do to it that is subtle going to change it. It's just about inputs and outputs, not structure.
Yeah, it's a highly innovated area, and it can become highly sensitized. There is no doubt about that, that the SIJ area can be a source of nociception. And so that's the challenge, right? Is we understand that it can be highly sensitized. What are we doing around that area that can modulate that pain? And I remember when I first started practicing, and the sacrum was a big thing, where there were people were palpating the inferior lateral angle, and assessing for rotations on different axes and these different things. And I was just like, wow, this is so confusing. I've got no idea what I'm doing here. I can't feel these different positions of the sacrum. But this sort of plays into our last episode with the guru that would say, no, you can absolutely you can feel for this left on left rotation around a right axis, or whatever it was. Okay. And I just felt so lost. I was like, God, I'll never get this. This makes no sense. And still now, there's no way that I could reliably and accurately say that I can palpate the position of the sacrum. No chance. But, and that's the thing, because when we look at the movement that's available through the sacrum, and as you said, some people say, well, there's absolutely none. Others say it could be between 0.6 to 6 degrees of movement. And could we reliably palpate that? Absolutely not. But again, people might have pain and sensitivity around that area. So what are we doing with our manual therapy approaches? Massage around that area, joint mobilization. Well, again, changing that sensory input, which can influence that motor output. So the muscle tone, the guarding, and again, the perception and the experience of pain. If we can apply this to create maybe an increase in endogenous opioids, a pain relieving effect, that we can then get that patient to progressively move through those positions that were uncomfortable and disrupt their previous belief or expectation of pain. So then we can, I guess, create positive neuroplastic changes. A number of things that can go on. That are probably more directed towards the influence of the nervous system and the experience of pain, as opposed to these structural changes. So, and you look at, again, look at the anatomy of the sacrum and the sacroiliac joint, and there's a robust structure of posterior ligaments and anterior ligaments, and then you've got numerous thick, dense, fibrous fascial tissue around that area. You've got numerous muscles around that location that is supporting that the sacrum, the pelvis, the low back. So it's a pretty complex area, and to say that we can that it goes out of place, or that we can adjust it and put it back in place, well, that can just have negative consequences on a patient's perception about the fragility of their body.
Yeah, and then what does that do to the way that they behave then? They're going to move in undesirable ways and limit their range of motion as a result. When you limit the range of motion of something, or limit the movement of something, then it starts to become functionally it starts to develop functional deficits, and then you'll lose elasticity of tissue, and therefore it'll feel stiffer and sorer, and then you'll have more pain. So it's the language. We come back to this again. The language is so important, and using words like release your sacrum. You can't release the sacrum any more than you can release the sutures of your skull. Like your brain is in there. It's pretty well protected by this, like this big giant dome that I've got up on my head. It is well protected. Those bones, if they could move with some subtle palpation and manipulation, then you better get yourself a pretty soft pillow when you go to bed because you're going to wake up with a crooked head.
Love that.
No, we got one more. What's your last one? The thing that
Oh,
won't release.
the last one is emotions. And so some out in the World Wide Web, people are still saying that they're storing emotions in their muscles, and that they can release these emotions with manual therapy techniques. And yeah, I mean, people have had experiences of big emotional releases from manual therapy, but that's probably not because, in fact, it's certainly not because there's an emotion that's stored inside the muscle, and by pressing on it releases that emotion, and you have this incredible emotional experience. So that is absolutely not what's going on. When we think about the limbic system in the brain, the amygdala and the hippocampus that are fundamental for the formation of memories and the emotional response that's associated with that. And the stronger the emotional response that is needed to form stronger memories. And you think about this, right? You'll really only remember memories that have a strong emotional response. So really good memories or really bad memories. You don't really remember the neutral memories because there's not a strong emotional response that's tied to that memory. And that's really what's essential for the formation of memories. Okay. And then you've even got the hypothalamus, which is essential for the nervous system function or autonomic nervous system regulation. Okay. And so when we think about the complexity of the limbic system, there's many different factors that are going on, but for even perception to reach our awareness, that requires the brain. Okay. And so you take the brain out of the picture and there is no emotion. There's no perception. There's no awareness of pain. And so, any textbook that I've read, or any research article, I've never seen an area in a muscle that's responsible for emotions. What about you,
So I,
Shaun? Have you?
yeah, I haven't either. But look, we could potentially be upsetting a lot of people here with this conversation because I'm sure there's people out there that have said, look, I store grief or anger or fear or something in my neck or my diaphragm or whatever, right? I think what's really going on is they've had an emotional episode, and they've linked the sensation of touch to a certain area. So I'll give you a contextual kind of very unique story. So I used to teach martial arts in the early part of my career, and one of the classes I was teaching, we were teaching people how to get out of a headlock. When someone puts you in a headlock, how to get out. And I had a mature female, and I was demonstrating her, and she's no problems. Yep, go for it. I put my arm around her neck, and I said, here's what you do. And then within a few seconds, she had this physical kind of breakdown. Like she had a very strong emotional response. And it came out afterwards that she had been attacked years earlier, had almost forgotten about it completely. And the person attacked her in the way that I was demonstrating in the class. I had no awareness of that. She had almost forgotten that this had occurred. But when she went back into that moment, the pressure around her neck, which was not done in a dangerous way, but the pressure around her neck told her that she had this fear locked in her neck muscles. And that was the story she told me afterwards. She goes, obviously, it's trapped in my neck. And I said, no, I don't think so. What I think was actually happening is you had like you said, a strong emotional experience that was tied to a physical experience at the same time. And so when people have their shoulder treated and then they cry, or they have their diaphragm treated and then they can't stop laughing, or like whatever it was, I think what's actually going on is that they've had a strong experience and those two sensations were linked. The sensation of the emotion and the sensation of pressure, touch, load, compression, something. And they've remembered it. There's a neurotag in their brain that makes them go, when I feel that, I remember this. Like you said, there's no ability for muscles to store emotions, feelings, memories. It's a sensation that our brain connects those two things for us.
Yeah, exactly. And thanks for clearing that up, because it's that association, that experience, and the brain is incredible at protecting us, but sometimes it can be overprotective. And so that protective response is based on previous experience and expectation. All right. And so the brain is going to try to be on one step ahead and try to protect us from potential danger. right? And so, absolutely, there can be trauma or a previous experience of injury or pain or whatever that may be. Um, and that's a learned response, which influences our behavior. But that does not mean that the memory or the emotion is stored in the muscle. It's the interpretation of that that occurs in the brain, and any sort of manual approach may influence that person's experience that was tied to that emotion, but it's not that it's coming from the muscle.
Yeah, and isn't it interesting then when people have a release of an emotion from their back, neck, shoulder, whatever, and they feel like that was the emotional release from the muscle, that it doesn't happen again a lot of times because they now associate with touch to that area as being a positive experience. And so if they were injured, attacked, assaulted at some point through their back or their neck, and then someone provides a caring, um, soothing kind of input, and then through that they have the connection and they have this strong emotional outcome. Then afterwards they go, oh, it's out. I feel okay now because now they've replaced it with a new sensation. It's not that we've released the emotion from the muscle, we've provided a new experience from which we can learn that is preferred to the old one.
Yeah, that context is so important as well, right? And as you said, that learned response. And so our brain is constantly changing. You may have heard of neuroplasticity is constantly changing. And so if we can sort of update that system, update that model with a feed forward learning response, and that can sort of, move away from maybe those unhelpful or experiences of pain or trauma. So, absolutely. I mean, manual therapy can feel great. It can reduce pain, but we're not releasing an emotion that's in the muscle. There's more to the story.
There's always more. Bo, um, I think this episode has maybe opened some eyes and upset a whole bunch of people, so I think maybe we'll leave it there. How about that? Good one.
Sounds
Thanks everyone
good.
for listening. See you next
Cheers.
time.